This morning I gave the first talk in a session on epigenetics in myeloma, and I was tasked with introducing the concept of epigenetics. And so I spoke about methylation of DNA and translational changes in histones which modulate gene expression under normal circumstances. And I then spoke about the abnormalities that are present in myeloma. And in particular, there's a marked abnormality of the methylome in multiple myeloma with quite global hypomethylation, which leads to dysregulated expression of genes and genomic instability. I then spoke about the dysregulation of HDACs, so histone deacetylases, where we've shown that a number of them are overexpressed in myeloma, and that in particular the overexpression of HDAC1 is associated with very poor outcome, so with early relapse and short survival. Then I spoke about the rationale for combining histone deacetylase inhibitors with proteasome inhibitors, because the area of protein homeostasis in myeloma is a very topical issue because of the sort of broad use of proteasome inhibitors in the disease. And I presented data which provides a strong rationale for the combination of those groups of agents. And I then spoke about autophagy, which is a process whereby cells can recycle proteins and organelles, and the finding that it's probably a critical capability of tumour cells which allows them to metastasize and become more malignant. And so I was able to present some preliminary data showing that this may be relevant in myeloma, particularly in a leukemic phase disease. And then finally I spoke about a phase 2 trial where we've used single agent Panobinostat in patients who've had induction therapy and an autologous transplant, but they've had a poor response. So these are patients who've not achieved a very good partial remission. And so patients were put on Panobinostat for a 6-month period. And we found that in 50% of these patients that they converted to very good partial or complete remission with the use of the Panobinostat. And if they did so, they could then remain on it as maintenance therapy. And we've seen further reductions in tumour burden up to 2.5 years following institution of the treatment. So we think this provides fairly solid evidence that there is single agent activity. It's just a matter of the patients being exposed to the drug long enough for it to, I guess, have an effect on the tumour. And in some instances we saw delayed responses which would suggest that the mechanism, at least in part, is due to immune modulation rather than a direct anti-tumour effect.